Well, thanks everyone for joining us via WebEx today. So as Jason introduced us, I'm Julia and my coworker Jackie, and we're both part of the RxFiles academic detailing program. And I also occasionally work at Shoppers Drug Mart just to remember what it's like to be out there in reality. And Jackie, anything you want to add about your experiences?
No, yeah, so as Jason mentioned, I was with the opioid stewardship team. I'm now working with the infectious disease clinic in Regina is where I'm located. And I work casually with RxFiles, and I became a part of this project when I was working with the opioid stewardship team.
Perfect. So today what we want to tell you about is what we're calling the RxFiles Opioid Agonist Therapy Project. And I wanted to come up with the longest title ever. So the subtitle there is Supporting Primary Care Providers with Academic Detailing Focused on Buprenorphine Naloxone. So that pretty much gives away our entire project. So we'll tell you a little bit about it. And at any point, as we mentioned, just in case you just tuned in, feel free to throw your questions or comments in the chat box or to interrupt. We welcome that. So today, I just want to quickly touch on what is RxFiles in case you're unfamiliar, talk about opioid use disorder and access to opioid agonist therapy here in Saskatchewan, sort of our environmental scan and why we chose to focus on buprenorphine naloxone, tell you about our project, just a little bit. Don't want to bore you too much, but again, you're more than welcome to ask for more detail throughout. What have we done so far? What is next? And then we'd love to hear if you have any questions, have some discussion, comments, or your thoughts as well. So quickly, what is RxFiles? Well, currently we're housed at the University of Saskatchewan in the College of Pharmacy and Nutrition. We used to be a part of the former Saskatchewan Health Region. So we are an academic detailing program, and we provide objective, comparative drug information to clinicians. So academic detailing is defined as that process of going to visit providers in their office and giving them evidence-based information that we consider balanced. So we never say A is better than B. We say, here's what we know about A and here's what we know about B. So you can make the best decision for the patient in front of you with that information. We're never trying to sell anything. We don't have any pharmaceutical industry funding. And again, we really emphasize the evidence, so evidence-informed or evidence-based medicine. And we want to provide sort of tailored education and support to the provider who's in front of us. And to help support us do that, we have print materials. So we sometimes have printed newsletters. We have a reference book that you might see in some offices. And we also have digital resources, so a website and an app. And our products and our services, which is academic detailing, are available free of charge to anyone in Saskatchewan. But we do sell access to our website and our books and our app outside of Saskatchewan, so say Alberta, anyone in the US, other parts of the world, and that just goes right back into our program to help fund it. So we're not for profit, but we're also not for loss, because our drug plan extended benefit branch funding, so the drug plan funds us, isn't enough to do everything we'd like to. But we're able to, again, supplement that by selling our resources. I'll throw it over to Jackie here.
Thanks, Julia. So in case you're unfamiliar with the term OAT or OAT, it stands for opioid agonist therapy, and it's medication therapy used to assist people in decreasing or eliminating their problematic opioid use. So that could be illicit or illegal use of opioids, hydromorphcontin or fentanyl that is purchased just off of the street, or opioid use disorder from prescribed opioids from our healthcare system. And unfortunately, access to OAT, which is a life-saving treatment, has been difficult in many parts of the country, but we are the same, and it has been problematic here in Saskatchewan as well. So from the RxFiles side of things, this is how we saw it. We felt that there was a disconnect between available addictions services, and that we were really lacking a coordinated and collaborative approach to addressing opioid use disorder in Saskatchewan. In Saskatchewan, in order to be able to prescribe OAT, you need to have authorization either through the College of Physicians and Surgeons or the SRNA if you're a nurse practitioner. And in order to do that, that requires mentorship. And there was minimal access to these OAT members, largely in part to the fact that we have very few addiction experts in Saskatchewan. It was also found that it's challenging for prescribers to coordinate wraparound services, so addiction counseling, especially in more rural and remote areas. And that could just be due to lack of availability or access or a lack of awareness of the services that do exist, or sometimes costs that are associated with them. Some providers aren't interested in working with this population. They are concerned about the problems they may encounter with the patient population. This could be due to stigma. It could be due to lack of support from where they're at, whether they're in a rural or an urban setting. Other demands, other workloads that are part of their daily lives, or maybe they don't actually see the problem that currently exists in Saskatchewan. We also noticed that there was a lack of Saskatchewan-specific educational resources related to this topic, and there wasn't kind of a nice, easy to go-to spot to find resources if you were looking for help and wanting to get started in this area. And Saskatchewan also lacked an addiction prescribers network, which other provinces had. So we found that there was lots of work being done, but often that work was in silos. So that was a bit of the problem that we saw just from our perspective. We also know that the opioid overdose crisis has caused a lot of deaths. And so this is always just a good reminder, and I like to pop these numbers up so we can keep in mind the impact that this is having in our province. So in 2020, we had the highest rates of opioid toxicity deaths that we've ever seen at over 300. That number says 269 there, but there's still another 67 that are yet to be confirmed. And in 2021, we're seeing the same thing. So as of beginning of May, that number was at 36 confirmed, but we're actually looking at probably over 130 at this point. So why is this a problem? Why does it affect us? Well, opioid overdoses, as well as just opioid use disorder in general, can be very costly. There's significant impact in costs for individuals as well as healthcare providers and on our healthcare systems. We know that people who are suffering with opioid use disorder spend a lot of time devoted to obtaining opioids. This can result in lack of personal relationships, but also lack of involvement in employment or other things like that. There's negative physiological effects of opioids, so the actual feeling of being in withdrawal or being dope sick, as well as overdose and death. And then the risks due to injection drug use. So in Saskatchewan, our HIV rate is 3 times higher than the rest of the country. And what makes us unique of the rest of the country is ours is driven by injection drug use. So over 67% of our new diagnoses are due to injection drug use. There's also societal impact. Illegal activities occur to create funds, to obtain illicit opioids, and the cycle kind of just continues. And so we proposed this project because we knew there was limited access to OAT prescribers in Saskatchewan, and we thought maybe we could change that. So the project began in spring of 2020. And at that time, there were about 107 physicians that were eligible to prescribe either buprenorphine naloxone, also known as Suboxone, or methadone. Now, so that's 107 out of about the 1,300 general medicine or family practitioners that are in the province. And keep in mind that some of these doctors that are prescribing are specialists, so they don't fit into that 1,300 number. So they may be like psychiatrists or infectious disease doctors that are prescribing. And so that number could be a lot higher. And then we had 7 nurse practitioners that were doing this at the beginning of 2020.
Gotta run the mouse over to unmute myself there. Thanks, Jackie. So based on this information, RxFiles applied to the Ministry of Health under what they had as titled as the Innovation Treatment Solutions Fund. And we propose that, you know what, we want to increase access to opioid agonist therapy here in Saskatchewan, and we want to focus on buprenorphine, naloxone, or Suboxone. And we want to do this by going out, doing what we do best, and that is assisting physicians by providing education and support related to topics around opioid agonist therapy. We wanted to help them navigate the opioid agonist approval process, and I want to say that cautiously. Essentially, what we would do is answer any questions they have that were easy to answer and refer them to their regulatory body to go through that process. And then once they became prescribers, if they were just getting started, provide that ongoing education and support to make sure they felt confident as they started to prescribe. So back in March of 2020, the funds were transferred to RxFiles, and they said, you have until the end of April to do what you have committed to do. And then you'll just see recently we did get an extension on our funding until July 31st. So we still have a few more months to keep working on this project. We are targeting primarily family physicians or primary care physicians because they are spread throughout the province. They are probably the most accessible for our population to access opioid agonist therapy. And of course, going after all the other healthcare disciplines, nurse practitioners can prescribe, pharmacists are dispensing, counselors, anyone who's interested, we would like to talk to them. We have an equivalent of one full-time pharmacist that we were splitting between two folks, myself as a 0.8 and Amy as a 0.2 up until April. We had Jackie and her in-kind support from the opioid stewardship program until January, and now she's on contract hours with RxFiles outside of her regular job. Our RxFiles team provided support, guidance, reviews, as well as external reviewers on any of the materials that we develop. So really quickly, why did we focus on buprenorphine naloxone? We know that there's methadone out there, and you know what, we focused on the sublingual buprenorphine naloxone formulation as well. There is an injectable depot as well as a rod that can be surgically inserted with a minor procedure. But we went out and said, you know what, the sublingual buprenorphine naloxone or Suboxone tablets is a great place to start because first and foremost, it's safe. Compared to methadone, what we're most commonly using, methadone carries about a 4 to 6 times greater risk of overdose than buprenorphine. So something we'd like to use when appropriate. It works. It's just as effective as methadone at preventing withdrawal and cravings when appropriately dosed for patients with opioid use disorder. It's well tolerated, and while safety might be an advantage of buprenorphine over methadone, so is its side effect profile. We see less sedation, less euphoria, less sexual dysfunction, and that's because of the effects on testosterone, and possible improvements in mood, especially around depression with buprenorphine compared to methadone. Another advantage over methadone is it may deter ongoing opioid use, and you can see the high binding affinity. Our pharmacists talk there. Essentially what it does is it just sticks so tightly to that opioid receptor in the body that when the patient or the individual might use another opioid, perhaps they return to use, that buprenorphine is going to hold on to that receptor and deny access to that other drug that enters the body, preventing that sort of reward or euphoric sensation that someone might be seeking by using. So it may help keep people sort of in recovery. And because it's a longer acting drug, especially compared to methadone, when someone misses a dose, it's not as likely to cause withdrawal. Again, I work in community pharmacy. We dispense both those opioid agonist therapies, and when my patients miss a methadone dose, they feel it. Buprenorphine, not so much. And it also offers the opportunity, depending on what dose they are on, to do alternate daily dosing. So we can double up your dose today so you can skip a dose tomorrow. And that offers some advantage, especially in rural and remote areas where pharmacy services might not be available, let's say on Sunday or maybe all weekend, or perhaps someone's lifestyle, maybe they're working, childcare, may not allow them to attend the pharmacy every day. So there are some advantages there. So this is why we thought, let's start with buprenorphine naloxone and see if we can support our prescribers around providing this medication. So we came up with some pretty lofty project goals. First, we said, of course, we want to increase the number of physicians who are going to provide this therapy here in Saskatchewan. We want to create tools and resources to support them in doing so. We want to figure out what the problem is. What are the barriers to access here in Saskatchewan? We thought we need someone to phone a friend, especially when individuals are working in those more sort of isolated or solo practices. So we spoke with the folks at Link, which is that consult service, and said, hey, can we get opioid use disorder added to your list of specialties? We thought, if that doesn't work, I wonder if MSB will actually provide a billing code for these remote opioid consults. So that goal 5 was sort of plan B to goal 4. We wanted to know if there were any additional wraparound opioid use disorder services available in the communities as we were going to go out and start talking to these physicians that weren't already captured by the Ministry of Health. And then we thought, hey, we need to help create this addictions network. And so what we committed to do, what we said we were going to go out and accomplish, is we were going to recruit. So we're sending faxes out to docs, personalized, saying, dear Dr. Smith, would you like to talk to Julia, Jackie, or Amy? And we are going to attend any event we possibly can to start recruiting docs to have a chat with us so we can help support them. We wanted to detail at least 200 physicians. So we want to make all sorts of great tools, again, to support our efforts. And we want to collaborate with relevant organizations and contacts, including the Saskatchewan Health Authority, CPSS and SRNA where appropriate, since they are approving folks to prescribe, and consult with the experts to make sure we're on track and to ensure we have that peer-reviewed resources and tools. Well, remembering that this all kicked off in March of 2020, a little pandemic occurred. And so it threw a little loop in our plan, as it did to everyone. And for the very first time in RxFiles history, we were unable to go see our docs face-to-face and provide that education and create that relationship and get into their communities and help figure out what resources were there. It eliminated the ability of physicians and nurse practitioners to get together with their opioid agonist therapy mentors to meet the requirements to become prescribers themselves. And conferences and in-person events were on hold, so we couldn't go out there and start promoting and chatting with folks face-to-face, because when Jackie and I are face-to-face today, it's really hard to say no to our offer for an academic detailing session. At least that's what I tell myself. So what have we done so far despite a pandemic? Well, right off the cuff, we decided we need to talk to the approved prescribers to figure out, what's needed out there. Turns out they didn't want a network. They already had their networks, like Prince Albert is a great example. They already had a system. They didn't need to be talking to folks in Regina and Saskatoon or La Ronge. And folks who were working in maybe other communities were happy with larger, more national groups like Medify, which comes out of Ontario. We managed to secure a funding extension because, again, COVID threw us for a loop and we weren't able to get out there, and it kind of stalled things while folks figured out this whole WebEx Zoom world. And we made some tools and we did some detailing and we did some presentations, but those last 3, we're going to give you a little more detail on here.
So we said we wanted to create kind of a landing point. We wanted a home for practitioners who are interested in helping people with opioid use disorder to go to and kind of find the resources that they needed. So if you go to our website, also the RxFiles website needed a little bit of a facelift. And so this is kind of part of the phase of upgrading our website, making it more user-friendly. If you head to rxfiles.ca/OUD for opioid use disorder, there's now a landing page that contains all of the resources that were created in this project, as well as some other adjunctive ones that we think may help practitioners who are managing patients who have opioid use disorder. Kind of the bread and butter or piece de resistance of this project was our newsletters. So we had a 4-page kind of teaser newsletter that went out more in the summertime, I believe, Julia. And then just recently, our 28-page buprenorphine naloxone kind of Bible, everything you need to know about using buprenorphine naloxone. Julia put the link there, and the newsletters were attached to the meeting invite. So if you would like paper copies of any of these things, you can contact Julia, but they are available online or in the email or in the meeting invite. We also wanted to make some tools for practitioners. So there's an infographic on microdosing, an infographic about just opioid use disorder and opioid use disorder in chronic pain. You can't talk about opioid use disorder without talking about harm reduction. So we have a new drug chart specifically about harm reduction and what you can talk to your patients about in terms of staying safe while using drugs. And that also goes hand in hand with these patient booklets. So that blue questions about injecting drugs image that you see on your screen there is a print paper booklet. We partnered with the Medication Assessment Center Interprofessional Opioid Pain Service, which is a new program based in Saskatoon, and received funding from SUOP. And if you're not sure what SUOP is, it's Health Canada's Substance Use and Addiction Program. And so they provided some funding to allow this partnership to occur to create these patient-specific resources that are available for free in Saskatchewan. And so if you would like to have these print resources at your office or in your clinic, definitely send an email out to Julia or myself, and we can arrange for those to be mailed to you free of charge. They are also available all on the website. And you can either print them off there or send them electronically to clients as well. A few other charts came up as we were working. We were like, you know what, this is what I see in my population, or this could really help me. And so that created the birth of our managing opioid withdrawal prescription and kind of action plan, as well as chronic pain and opioid use disorder concerns, and as well as acute pain management for people on chronic opioids or opioid use disorder. So we hope to have answered a lot of the questions that I know I had with my clients and patients, and so hopefully you'll find these resources helpful for yourself as well. The next page, this is just a quick teaser of what the landing page looks like. So again, rxfiles.ca/OUD, and you can find all of our resources there. If for some reason you're not on a health authority computer, or you're having trouble accessing these, sometimes your computer just needs to be set up in the RxFiles system. So you can reach out to Julia and she'll get you set up so that you have access to these materials.
All right, and in terms of our academic detailing, our bread and butter of our project, we got out there in round one with that 4-page teaser because we didn't want to overwhelm anyone. We had about 343 healthcare providers, and I was a little surprised that when we were going out in detailing, so many of our providers, regardless of if it was a physician or nurse practitioner or pharmacist, were starting at square one. They said, start from the beginning. I know very little to nothing about this particular medication. So far, we've spoken with about 149 physicians. Again, our goal is 200. The medical residents and nurse practitioners, you can see the numbers there. And we hope to hit our 200 physicians with round 2. So there's my shameless plug, Julia at rxfiles.ca. Call today, or I guess email, to book a session. It's open to anyone in Saskatchewan, whether you're a clinician, an administrator, anything. We can adjust our content for you for a 15-minute, give you the highlights, to a, hey, I really want to get down to the how do I do this? Can we chat through that? More than one session. Right now we're doing it via WebEx because, of course, the pandemic, for safety reasons. So if you would be interested, don't ever hesitate to reach out. And again, if you need any of our resources, don't hesitate to email.
And just to interrupt for a second,
oh, yeah?
Julia, I just wanted to say something that was a bit different about this topic is with RxFiles, we're generally kind of a one and done. We cycle through our topics throughout the year, but we really wanted to be there as a support, especially for prescribers who may be dabbling in this area. So the first visit for many was just kind of a, hey, this is out there. This is why it's important. Let's talk about this. How do you think you can maybe fit it into your practice? And then if physicians were like, yeah, I'm interested in this, let's do this, we could set up a separate visit to go through the nitty gritty and like, okay, this is how it specifically will look. These are the tools that will help you in your EMR. These are people you can reach out to, and kind of getting into the details for what you need to order for monitoring and what you can expect to see. Sorry, Julia.
No, perfect. Thanks. That gave me a moment to see that someone was warning me that I had the gray chat box in the way. Thank you for that. So in terms of our detail, you can see we talked to 343 people, and we always like to send a follow-up survey to make sure we're on the right track and get that sort of anonymous feedback. And 25 folks have so far taken the time to respond, so not a great response. So take what we have here with a grain of salt. But what we do know from that round one is folks generally felt that they had more confidence in this drug therapy area. So we were happy to hear that. And they also commented we had sort of our three key messages here. It's easier to prescribe than methadone, and there's a whole bunch of sort of caveats around what we mean by easier, safer, and similar efficacy. We saw that the folks who partook in our session said, yes, you know what, this either will change my practice or this really confirms what I'm already doing. So we were happy to see that. And those that say it does not apply to me, that's because they assumably are not, rather not approved prescribers yet. And this is the one I was really excited about. So at the top, this was so how did you feel sort of before our session? And at the bottom, it was, how do you feel after talking to one of our detailers? And the first question said, I wasn't even considering buprenorphine naloxone in my practice. And about 42% said, nope, wasn't even on the radar. After talking to us, it was 0. So we moved them along that sort of behavior change spectrum, which was our goal. It was another reason why we went back to the ministry and said, can we have a little more time? Because we managed to move folks one step. We want to see if we can continue to support them to move along to the I am now ready to prescribe buprenorphine. So we thought this was pretty favorable and exciting information to get from our participants.
And we definitely tried to be as efficient as possible and sometimes grab as big of an audience as we can. So this topic had a bit of a combination of one-on-one, those individual academic detailing sessions, as well as larger presentations, including some for the Canadian Society of Hospital Pharmacists, RxFiles. We held our first ever conference this past February that had over 1,000 family physicians at it from across the country. So we spoke on this topic there. And we also just targeted any group that wanted more information. So the Regina Hospitalist group reached out to us, and we did a presentation with them, different medical residents, different pharmacy groups, community, hospital, basically whoever thought they wanted a little bit more information in this area. And so if you feel that a presentation may be good for your group, definitely reach out to Julia. As she said, we can always tailor the content to meet the needs of our attendees. And now, while the pandemic brought a lot of challenges, it also was a bit of an enabler in that it allowed us to connect to clinicians via other messaging or either via other platforms, which prevented the need for us to travel places. So as Julia said, RxFiles is generally a traveling road show, which isn't always great in the winter time. So we were able to avoid kind of these wintry, awful roads, but it can also be challenging in the summertime as well. And where was this picture taken again, Julia?
Highway 55, just outside Nipawin.
Yeah, so we were able to avoid some physical barriers that may have prevented us from reaching different clinicians. And it was nice because I could be in Rosetown by 11 o'clock and then in Estevan by 1 o'clock p.m. So we could hit multiple places in the same day. And it got easier as different clinicians learned how to navigate Zoom and WebEx and things like that. It's also a little bit safer. We've had detailers hit wildlife. We've had detailers get struck by lightning. So it's a little bit nicer to be in the safety of our own homes at times. And also it allows us to do things like this. So Julia is in Saskatoon, I'm in Regina. Not very often do we get to be in the same place to present together, but being in a virtual land, we're able to piggyback off of each other's knowledge and expertise and dare say make our presentations a little bit more dynamic.
Nobody wants to listen to me for a full hour, that's for sure. All right, 2 more slides to go. So we asked the question, especially for doing this presentation, where are we now with that #1 goal of increasing access to opioid agonist therapy by increasing the number of prescribers? So we sort of had a midterm report we gave to the ministry in September, and then we just ran some numbers for April because that was the most recent ones we had. And we can see that in the April column, we have 23 more physicians who can initiate both buprenorphine and buprenorphine and methadone, but by no means are we able to take credit for those numbers. We don't know if those were our efforts, if these prescribers were already en route, if they were convinced for whatever reason they may have had. We also can't explain the negatives. Did someone leave the province? Did they go from an initiator of buprenorphine naloxone to initiator of methadone and buprenorphine? We don't know, so we have some unknowns. But what we will do by the end of the project, as we're wrapping up, is we are going to work with the drug plan, and we are going to have them run sort of an aggregate anonymous form. We're going to give them the names of who we detailed, and they're going to run that and tell us if they ever wrote a prescription and for how many beneficiaries. So did they just write it for a one-off? Maybe they had that one patient, or did they sort of find a few patients in their practice? And so we won't know which ones actually did in the end, but we'll know whether or not our project had an effect. And if it did, perhaps we'll continue on. And if not, we'll go back and see what we could maybe do differently in the future. And so what's next? Our last slide here. Well, round 2 of detailing on buprenorphine. Got that 28-pager, the how-to. And just in April, we sent about 1,200 physicians fax requests to say if they were interested. I think I've got about 30 back. We're going to continue to see if we can get opioid agonist therapy listed on LINC, and the LINC service at MSB, the Medical Services Branch, has been phenomenal to work for. They've just been, let's see if we can make this happen. So that's been a great partnership. And then as we approach the end of July, which, my goodness, I think we'll be here before we know it, we'll just do our project wrap up and final reporting. And of course, we'll still have all our resources available to everyone, but we will have to stop with our academic detailing focused on this topic. So just a few moments over, but now I'd love to open the floor for questions, thoughts, ideas. Leave my email address up there again for a moment in case anyone wants to make any requests. And Jason, maybe we'll throw it back to you.
Sure, yeah, thank you very much for the talk. I guess let me just start right there. Does anyone have any burning questions that they want to ask? You can either feel free to pop them in the chat or just unmute yourself and ask away. And I always have a burning question, so I will start and let people sort themselves out. I guess for me, and it's a bigger picture question. So I'm wondering from your guys's opinions or thoughts, or from where you're sitting, what is the disconnect, particularly in Saskatchewan, in terms of fixing this problem in the big picture, right? So, and so what I mean by that is, like you showed, the number of overdose deaths, you know, how we can help prescribers to learn and do, you know, take part in these types of things. And yet we've got the last budget chose not to provincially fund, you know, a safe consumption site. We've got, I think it was Fort San, where there was such, you know, upheaval in the community at the idea of a treatment center being moved, I think, from Indian Head to Fort San just recently. You're talking about hesitancy amongst prescribers to even take on opioid agonist treatment as an option for them. So from where you guys are sitting, what is the disconnect that we have when we've got all this good evidence from what I see about things we can do to make this better, and yet we're just not able to fully act on it?
Oh boy, way to open a can of worms, Jason. All right, maybe I'll start, and I'm going to say this with a couple caveats. This is my personal opinion, my experience, and remembering that I spend most of my days in this beautiful fake world, and then we'll let Jackie, who's really out there in reality facing it, comment. But I think in terms of increasing access and the challenges around primary care, is our primary care providers are busy, and there is a huge demand from their patient population, and there's only one of them or a small practice, and I find they're just generally not wondering what to do next. They're struggling to stay on top of things and probably deliver care at the level they'd love to do it and the time they'd love to spend with their patients. So now we're asking them to take on another disease state to get some additional training, get approved by the college, and figure out how to integrate this into their practice. And many of them are, and some of them do, but you can see how that's a bit of a tough sell to go, hey, I need you to do one more thing with a really complex patient population who's probably not going to be as successful with their therapy as your hypertensive patients, as your diabetes patients, because it's a relapsing chronic condition, right? They're going to slip, and it can be tough. And when you don't have mental health supports in your community to help you treat that patient, I get the reluctance. I really do. And we do have some evidence that says, some drug therapy is better than no drug therapy. And drug therapy and counseling is even better than just drug therapy. And I think if we can help them understand that message and make them feel comfortable, we'll make a little bit more headway. And maybe, Jackie, I'll leave you to talk about maybe around the stigma and the political environment that comes with safe injection sites and the challenges there, because you probably see it way more than I do.
Yeah, so again, same disclaimer, my opinions are my own and not SHA or RxFiles, but I think we cannot prescribe our way out of this problem. So this project is not going to solve the opioid use disorder problem, but access to treatment is a huge barrier right now. And unfortunately, it's hard in Saskatchewan. As Julia said, primary care physicians are very busy. It's hard for them to become prescribers right now. They have to do an online course. They have to find a mentor. They have to do this mentorship, and then throw in the pandemic, and that makes it a lot trickier. So one, just access. Everywhere says that we need to meet people where they're at, and we don't meet people where they're at. It's hard. We have a harm reduction clinic here in Regina. They do amazing things. They are lacking capacity, and despite my best intentions of setting up rides and things and getting people to where they need to be at the right time, sometimes there's not a doctor there, and sometimes they can't get in for 3 days, and 3 days in this type of instance is a matter of life or death. It really is every single time. So prescribing is one thing. That's one piece of it, is helping people get out, but there's another piece of keeping people safe now, and we can't just throw money at one thing. So we put a lot of money into naloxone kits. That's great. They're still not as accessible as they should be, but we don't have funding for safe injection sites. We don't have funding for that mental health aspect, just safe housing, eliminating some social chaos, getting people to where they need to be. So it definitely needs to be a multifaceted approach with continuity of care amongst the different systems, whether that be mental health and addictions, inpatient acute care, and community care, just better communication. And then throw in a bunch of stigma on top of all that, and making people not want to access care to begin with, and you kind of have a perfect disaster.
Yeah, that's, I think, very, very poignant that there isn't one magic button you can push to fix this, right? Otherwise someone would have pushed it already. So and I think, just to come back to what you guys talked about today, I think it's fantastic that RxFiles has been able to get the funding to do a project like this, because again, it's one more weapon in that arsenal to help try and fight this problem or fix this problem, whatever analogy you want to take. Any other questions? You've blown everyone's minds today. That's great. I love that pivoting too, right? And I mean, any research project, right, is you got something and the pandemic hit, and I was like, okay, now what, right? So I love, that being able to pivot and make use of the virtual means to connect with people and to highlight to the ways that has actually helped potentially to improve the spread of this and allow you guys to reach more people. So that's absolutely fantastic. Okay, some thank yous coming in, so I guess we'll stop there. Once again, thank you very much to Julia and Jackie for taking your time today. Any final words from either of you?
Again, don't hesitate to reach out if you just are wondering if we have a tool that can help you. If we don't, we'd love to hear from frontline providers that there's a need for a tool, because then hopefully we can put that together. So I always say all you can do is ask, and we will do our best to help support you with any information around this therapeutic area.
Excellent.
I don't have much to say. Wear sunscreen. It's sunny out today.
Thank
Harm
you.
reduction.
That's good. Okay, well, thank you again very much. And we will see everyone hopefully back here next month for something antimicrobial stewardship related.
Thanks,
Have a good
Jason.
day, everyone. Yep.
Thanks, everyone. Thanks for your time.